Thank you so much for having me here today. I'm going to talk to you about the PUMA study, which is a large 5-year multi-centre study focused on improving paediatric early warning systems. I have the honour of presenting on behalf of a large multidisciplinary and multi-skilled team who are named here. There has been a growing concern about high rates of paediatric deaths in the UK, including those attributed to failure to detect and act on deterioration. PUMA was commissioned by the National Institute for Health Research to look at interventions to reduce mortality. We worked with 4 sites across the UK, 2 tertiary centres and 2 district general hospitals. The initial focus of the study was on developing and implementing a paediatric track and trigger tool. These tools have been a popular response to the issue of misdeterioration, but as I'll explain shortly, the studies from the systematic review led us in another direction. Our revised aims were to develop and implement an improvement programme rather than a single intervention, evaluate its effectiveness, and identify the key ingredients for successful implementation and normalisation. I'm going to talk briefly about the study design and then report our findings from the study against each of these 5 aims. The 5-year study was designed in 2 work streams. Work stream 1 involved reviews of the evidence, development of the intervention, and implementation package. Workstream 2 was a mixed methods evaluation combining interrupted time series of core and secondary outcomes, including mortality, cardiac arrest, respiratory arrest, and unplanned admission to HDU, and embedded ethnographic case studies, which involved observations of clinical practice and staff and parent interviews before and after implementation. We also incorporated a qualitative process evaluation to review how the intervention had been implemented and received. So why did we change our focus from a track and trigger tool to an improvement programme? Systematic reviews showed very little high quality evidence on the validity and effectiveness of paediatric track and trigger tools at reducing mortality and critical events. There was also limited evidence on the effectiveness of core components of paediatric early warning systems, but a lot of information about failure points within systems. Lots of different interventions were mentioned in the literature, few of which had been evaluated in different settings. However, there is emerging evidence that a combination of interventions may be effective. The systematic reviews on contextual factors highlighted a number of preconditions for track and trigger tool use. In short, the system, in terms of availability of equipment, staff and skill mix, had to already be working effectively for a paediatric track and trigger tool to have its effect. The tools perhaps have more value for more junior staff. The tools are not capable of capturing deterioration in, for example, patients with long-term conditions who have altered physiology. In these instances, you still need experienced staff who are able to exercise professional judgment. Paediatric track and trigger tools can have value, particularly in coordinating care and providing a language for communication between doctors and nurses, but an effective paediatric early warning system requires more than just a single tool. It's reliant on the local context, on senior support and leadership, and on the ability to continuously monitor and evaluate the system. The third aim of the study was to develop and implement an improvement programme. The programme was underpinned by a novel approach to improvement called Outcome, which is a theoretically informed approach bringing together learning from the fields of implementation science and quality improvement, and is designed to harness local expertise to better understand what problems are occurring and how best to address them. Defining a system standard is a core part of the Outcome approach. This is basically a model of what is required in practice for a system to work effectively. The PUMA system standard was developed by synthesising the evidence from the systematic reviews, clinical expertise, patient and public involvement, and social theories to specify the minimal requirements of an effective system for detecting deterioration in children. This is a visual summary of that much more detailed model on the left-hand side of the screen. Essentially, there are 3 elements to the system: detect, plan, and act. And the more detailed model outlines the minimal requirements for the system to work effectively in practice. Another core part of the Outcome approach is engaging healthcare professionals in the improvement process. This wasn't the study team telling them to implement a particular intervention. This was about drawing on their expertise to identify areas for improvement and identify the solutions that will work in their particular setting. One of the key tools we provided to teams was a system assessment tool, which was essentially a set of questions derived from the PUMA standard to enable sites to work out how well their own system was functioning. These were designed to be completed by representatives of all staff groups and by families of children in the hospital, the findings of which were collated by the improvement teams. The system assessment tool and the details of the 5 steps for improvement were provided in an implementation guide. We also provided 2 facilitated sessions for the original 4 sites that were enrolled in the study. An additional session on implementation was added for the subsequent 3 pilot sites. So if we look at the effect of the programme on clinical practice, these diagrams show a summary of the results from the system assessments. So the orange is how well they scored on Detect, the blue on Plan, and the green on Act. As you can see, there's a reasonable degree of variation between the 4 sites, highlighting that each has its own fingerprint, different strengths and weaknesses requiring different actions to improve. In addition to this visual summary of their system, they created lists of strengths and weaknesses and were guided through a process of prioritising their areas for improvement. Some highlighted communication problems between doctors and nurses, ranging from separate handover sheets, separate ward rounds, and the lack of opportunity to share information. Others found that staff were unaware of supposedly established procedures set out in observational escalation policies. One site found they simply didn't have the right equipment available to conduct timely and appropriate observations. Some of these issues were known to site leads, but others were unexpected. Sites then discussed possible solutions. This table shows the 15 improvement initiatives that were embedded in practice. These were as varied as the problems identified, again emphasising the need for context-specific solutions. It's also important to highlight that most of these initiatives were process changes rather than an introduction of a new tool. These changes were often relatively simple to implement, for example, more frequent phone calls, and don't come with a big associated cost burden. It was fascinating to see how much sites managed to do in often difficult circumstances. There was an appetite to address the issues that had been identified and an enthusiasm you don't generally see when trying to implement an externally developed intervention. Assessing the impact of PUMA programme on quantitative outcomes was problematic. Although mortality, cardiac arrest, respiratory arrest and unplanned admission to PICU and HTU have been commonly used to assess paediatric early warning systems, in practice they occur infrequently, which was particularly apparent in district general hospitals, which saw smaller numbers of patients. These figures show fitted lines for pre-intervention, implementation and post-intervention rates of adverse events per 1,000 patient bed days. For all figures, the solid red line represents observed fitted trend lines. The dotted red line represents projected trends based on a continuation of the pre-intervention trajectory, and the dotted green lines represent 95% confidence interval around the observed fitted trend line. So, although the solid red line suggests that after the PUMA programme was implemented, there is an overall reduction in the occurrence of the primary outcome, which was a composite measure of mortality, cardiac arrest, respiratory arrest, and unplanned admission to PICU and HTU, the green dotted line shows a very wide confidence interval. It's also important to note that what we captured here is inevitably a result of other factors. None of the paediatric early warning systems remained static. In some instances, there were major organisational changes that impacted on the early warning system. For example, implementation of the PUMA programme in one site coincided with the Care Quality Commission report, which led to large-scale mandated organisational level system changes, all of which addressed areas of weakness identified in the site system assessment, but were not formally part of the PUMA study. Nevertheless, several of the clearer quantitative findings appeared to relate to the qualitative observations. The multiple organisational level changes mandated in response to the CQC report in Site 1 were associated with significant improvements in clinical outcomes. As another example, Site 4 implemented several organisational level system changes at an early stage in the study, which coincided with a decreased slope in adverse event rates. The interrupted time series analysis gave a mixed picture, which would likely have been clearer if we'd collected data over a longer time period. The final aim of the study was to identify the key ingredients of successful implementation and normalisation of the PUMA programme. These were quite simple. You need a team, you need to engage the people, the nurses, the doctors, the care assistants and the families of sick children who have experience of the system and are better placed than any to understand where the issues arise. You need leadership within that team to help navigate the inevitable challenges of system change, and you need an organisation that supports this approach, that has an appetite for improvement and systems in place to support it. In conclusion, a single tool is not the answer to missed deterioration. While paediatric track and trigger tools have value, they rely on the system already working effectively to have their effect. Paediatric early warning systems are complex and dynamic. They are shaped by the local organisational context and are constantly changing in response to shift patterns, technology, the space in which the service is provided, and other organisational changes. The PUMA programme offers an approach that standardises improvement across different sites, but supports and enables locally relevant solutions to be implemented to address locally identified issues. Implemented at scale, there's the potential for shared learning across healthcare systems, where organisations with similar contextual conditions share successful approaches to the same problem. Those delivering and receiving services are best placed to understand the issues within a system. Providing them with a way to systematically collect that information and plan their response was a powerful tool for improvement. There is an appetite among healthcare professionals to be involved in efforts that make their systems work better. This work needs to be written into job descriptions, and organisations need to ensure that their staff have time and recognition for their efforts. Further research is required to see how easily the approach of developing a system standard and supporting teams to identify issues and implement solutions could be applied to other areas. Further research is also required to develop more effective outcome measures for paediatric early warning systems. Thank you so much for listening.